Going to look into the more in depth about hypoxia and how to challenge for this and how to treat it. And then the aim is to put it together and do a demonstration so that you can see how you would approach a patient. Okay, so you can actually see it, and hopefully we'll do it with some good close-ups with Gary. And we're also going to do a demonstration to see the effect on the cardiograph with using mobile phones. So that'll be quite interesting as well. So eyes into distortion is where we got to. Okay, so a protocol for hypoxia. The first thing we've got to do with hypoxia is to change a person or get them into weakness. And to verify that they're hypoxic, you need to have somebody who strengthens to O2 or oxygen. So you could take a person to weakness through the phonocardiograph. So you play the phonocardiograph back through the headphones and they go weak with the subscapularis, or if you're using the emerald, then all muscles go weak. So you're in weakness. If you use the ordinary stethoscope, then you plug the stethoscope into the patient's ears and the diaphragm is on their heart, and then the muscles likewise go weak. If you're using the beginning and ending points, you use the meridian, which is usually the causal one, will be the one that will respond to the hypoxia. But we'll see that when we deal with Sylvia as our patient a bit later on. Okay, so remember before the break, we looked at the two meridians, and one of them was more the cause of the other one, cause and effect, or what would be a nicer way of putting it would be genotype and phenotype. So the phenotype is how that person is expressing those genes at the moment, or expressing the body. So this is where you would get toxins, infections, maybe mechanical problems, maybe deficiencies of minerals and things will show up. But with the fundamentals, the genotype is where the big boys come in, like hypoxia and severe deficiency. So nothing really, that you're born with will be adjusted by allergies. Physical treatment won't change your genes at all. They're not the big issues. You don't change a person's genetic structure by adjusting their neck, but you can make their life an awful lot better on the phenotype. Okay? So when you're looking at a genotype, you're looking at something which is more genetic, which is why you'll find the coenzymes of the things which correspond to the genes will be the things to chart. So from weakness, patient strengthens to hypoxic eye position. That would be up and down, the aerobic challenge of up and down. Confirm using oxygen. So you could use a whiff of oxygen, or better still would be to just put the, or not better, but for most of us, would be to put the vial of oxygen on. Now interestingly, I made that by putting catalase, which is an enzyme we're going to talk about in a minute, with hydrogen peroxide. And when you mix hydrogen peroxide and catalase together, you end up with water and molecular oxygen. So the gas that comes up is oxygen, and that's how I got pure oxygen to use as the original sample for the oxygen vial. Okay, so confirm with oxygen. And then we look at the process of how we get oxygen from here into the cell. So if we think about it again, oxygen has to go through the lungs, it has to go through the alveolar, into the blood, into the red cells, out of the red cells, across the cell membranes, it's across the mitochondrial membrane, and into the mitochondria. Okay, so it's a long sort of journey to get there. But we can abridge it because the first pathway of getting it across the cell membranes involves diffusion, with simple change of pressure, to move it from the area of highest pressure to the area of lowest pressure. And that means you've got to get it across the membranes, and all those membranes are made of oils. Okay? So phospholipids, which make up the cell membrane structure, which we've talked about a lot in the past, are all made of oils. So a brief summary of that will suffice. But what sort of oils does the person need? So let's have a look at the options. Now we could just challenge them with the different individual fatty acids, or better probably is to just challenge them with the oil that we might prescribe. So possibly here would be your GLA ones, gamma linolenic acid ones. So evening primrose, blackcurrant seed, BSO, and borage or starflower. So those will be the rich sources of GLA. Black cumin, you talked briefly about those black seeds curing everything apart from death, that the Prophet Muhammad said. So black cumin seed, very interesting oil, because we found that 1 teaspoonful of that has the same amount of DHA and EPA as one capsule of fish oil. So it's one of the few land-based oils which actually has DHA and EPA in. So very good alternative to people who can't take the fish. You know, particularly blue people who are very sensitive to mercury, which would be in the fish. Flax and chia, good, very good omega-3 oils, alpha-linoleic, maybe 60, maybe even 70 chia oil of alpha-linoleic. Grapeseed oil, hazelnut, hemp, again a good blend, hemp, excellent hemp. Macadamia nut we find is very good, rich in palmitoleic acid, the same ones we talked about in the last seminar, I think, which are rich in sea buckthorn oils. Olive, coconut oil, fantastic against with fungal problems, you know, with those mid-chain fatty acids, C8, C9, C10. Peanut oil, pumpkin, beautiful oil. Omega-3 oils, fish oils, the ones that we suggest there. The smaller the fish that it comes from, if you have to use fish oil, and I try not to prescribe fish oil, but there are some people who do need EPA, DHA from fish oil. Remember, virtually never prescribe it to a blue person because there will always be an element, although it might be minuscule, of mercury in fish oil concentrate. But apparently the smaller the fish, the less the pollution. Bigger the fish, the more they accumulate because they can't detoxify. So the old cod liver and halibut liver oils, you know, are much higher in the mercury. Or the omega-3s, which are from sprats and anchovies, the small fish seem to be the better sources of that. Beyond that, I don't want to say too much because there's only a few companies in the world who do soft gel caps. You know what a soft gel cap is? It's gelatin cap, as opposed to hard gel caps. And they all use the same oil. So if you buy your oil caps, and I know the company that manufactures them, they use the same oil that one company uses and another company uses, you know, the question is there any difference in the oil? And the likelihood is probably not. So you can pay more for an oil, you can pay less for an oil, but I'm not convinced that one particular oil is of a greater quality than others. The bottom line is muscle test it, and always test it for tolerance. Okay, don't just test it, the fact it strengthens, but test the oil product. Because sometimes it's not the oil which is the problem, sometimes it's the capsule. You know, we do find sometimes that oil on a spoon is a lot more tolerated than oil in a capsule because the gelatin capsule isn't very good. Now hard gel caps are much better because they're made of vegetable gelatin, but soft gel caps are still made from fish gelatin or beef gelatin. Okay, there is no vegetarian soft gel cap. We used to think they had great hopes 5 years ago that it would work out, but they all melt. Okay, given 6 months down the line, they've all gone all soggy and melted. So, you know, there's no point in putting fish oil in a vegetable gelatin. You might as well put it in fish gelatin. But there are times, and this is interesting, when people weaken to the capsule. And it's not the oil that weakens to, sometimes it's the capsule itself. Walnut oil and WGO is wheat germ oil, which is really nice because we know that's a fresh wheat germ oil is a wonderful source of natural vitamin E with all the tocopherols and tocotrienols. So that would be your phospholipid. So if a person who's hypoxic strengthens to phospholipid, so we do a marker, which is a composite of phosphatidylcholine, phosphatidylethanolamine, phosphatidylinositol, sphingomyelin, and so on, all the phospholipid structures. Now, the second would be, does the person strengthen to hemoglobin? This is the molecule that carries the oxygen in the red blood cell. Okay, and this is really, really important molecule because a lot of people on blood tests have low hemoglobin levels, but their iron is normal. Iron is a component of hemoglobin, and previously I would have said you check iron and you check B12 and that would have been it. But we never studied hemoglobin to a depth to know what it's really made from because it's very complex. So we're going to look at that in a little bit more detail and see what these intermediate substances are. And finally, we might consider CoQ10, which is the carrier of the electron, but it also bonds the oxygen on the mitochondrial wall. So it has a role in people with hypoxia. So this is just a summary of how we get oxygen. Oxygen in the air, across the alveolar, across into the red blood cell. red blood cell across the membranes, tissue membranes, and passing down in the tissue membrane, mitochondria, and finally into the mitochondria itself. Now, let's just remind ourselves of reactive oxygen species, because we're going to be talking, about oxygen a lot today, because that's the major finding we find with hearts. Let's just have a look at this chart, which I actually did many years ago and revamped. So on this side, we've got reactive oxygen species, as they're called, and we get superoxide, which is the O2 with a dot on it, from normal mitochondrial oxidation. So anything up to 5% of normal oxidative processes in all of us, in every cell, will produce superoxide, just 5%. But we increase that during a respiratory burst, which is when we increase our metabolic rate when we've got an infection. So we increase our body temperature. This increases the amount of free radicals that are produced in order to kill off infections. We increase it during phase 1 detoxification. So for every molecule of a toxin or a xenobiotic that we detoxify in the body, we produce 1 molecule of superoxide. This is why people who live in toxic environments age much quicker. When you go to a real toxic environment, people look 10, 20 years older than what they actually are. Okay? And number 4 here is hypoxia, or occasionally hyperoxia, when people have got too much oxygen, which is unusual because that would be in a hyperbaric chamber in most cases. But for most of us, this is hypoxia. So in a hypoxic state, we will actually generate more free radicals. Okay, so we may be coming in at 98% oxygen, but 98% oxygen means you've got 2% down, you've got a greater tendency to produce more xanthine oxidase with more superoxide. Now, superoxide is normally reduced by superoxide dismutase. Superoxide dismutase can be zinc, copper dependent, manganese or iron. This then forms when you have this is the first electron. Second electron produces hydrogen peroxide. And hydrogen peroxide will then become, with a third electron, to produce hydroxyl radical, or be reduced to water and oxygen by the main enzyme, preferred enzyme, which is called catalase, or glutathione peroxidase and other peroxidasing enzymes. Okay? So all very interesting because they've all got the name peroxidase, which means they reduce peroxide to water. Okay? Now, hydrogen peroxide can be then converted here as an alternative by an important enzyme called myeloperoxidase to produce hypochlorite, hyperbromide, hyperiodide, which are the killing radicals to kill bacteria. Okay, you've all heard of hypochlorite. It's household bleach. Okay, that's why household bleach kills germs, because it's a chloride oxidizing agent. Now, over this side, we produce nitric oxide. Nitric oxide is a free radical. It's got NO with a dot on it, and it's made from the amino acid arginine. So arginine is converted to nitric oxide by an enzyme called inducible nitric oxide synthase, INOS for short, which is a tetrahydrobiopterin, H4-biopterin. Remember, that's a coenzyme in the folate family. Okay? So this goes on to make nitric oxide. Nitric oxide will combine non-enzymatically with superoxide to produce peroxynitrite, which converts over, interchanges with hydroxyl radical. So you see the two reactive nitrogen and reactive oxygen species are linked. Now, all very interesting, all very complex, but there's a link here. All the enzymes which are underlined, okay, normal mitochondrial oxidation. This occurs in the mitochondria, and we'll see this needs CoQ10, but it needs cytochrome C, was the other carrier molecule. Phase 1 detoxification. These are called cytochrome P450s, which I'm sure you're all familiar with. Myeloperoxidase, in order to kill bugs. Catalase, which reduces hydrogen peroxide. NADH peroxidase, other peroxidase enzymes. Nitric oxide synthase, underlined. These are all heme-dependent enzymes. That means when we make hemoglobin, before we make hemoglobin, we make heme, which then has amino acids added to make the globin part. So these are all heme. This is the important part we need to understand. How do we make heme? Because if you're hypoxic and you strengthen to hemoglobin, it means you're deficient in heme. Okay? And heme is a complex substance which is the base substance of inducible nitric oxide synthase, cytochrome P450 in the mitochondria, myeloperoxidase, catalase, and other peroxidizing enzymes. What does that mean? If you're hypoxic, you can't produce heme, your immune system's no good because you can't produce nitric oxide here and you can't produce myeloperoxidase, right? You can't detoxify because your cytochrome P450s aren't functioning properly. You're tired because your energy isn't being produced in the mitochondria, and you're pumping out hydrogen peroxide, which is highly inflammable because you're deficient in catalase and other peroxidase enzymes. What would that give you? It will give you low immune system, tiredness, and pain. Okay? Isn't that what all our patients come to see us about? And you begin to think, Chris is talking sense. No wonder our patients are hypoxic and have tiredness, pain, low immune systems, and are basically shot through. Tired, detoxification, immune system. Why do we have free radicals? The answer, as I said before, is to kill bugs. So these hypochlorite, these halogens here, kill gram-positive bacteria and viruses. Hydrogen peroxide is there to kill parasites. No question about that. Nitric oxide kills gram-negative bacteria, viruses, and certain fungi. And peroxynitrate kills viruses, fungus, and some parasites. So they're all there for a reason. They're there to kill, but we don't want them active if we haven't got microbes in there. So this is why we need to remember, and the emphasis on this is, when we come to working out the people who are deficient in hemoglobin, because they're hypoxic, because they're deficient in hemoglobin, will have all of these, but there's worse to come. Far, far worse, because one of the most important enzymes is sulfite oxidase, which is heme dependent, which means they can't drink wine and beer. And that's more serious than anything else. Okay? The only saving grace is they can drink spirits, because sulfites are put into wines and beers, and sulfite oxidase is a heme dependent enzyme, amongst other ones which I'll introduce you to. So oxygen transport is from the lungs. You can read this because we know that 78% of air is nitrogen, 21% is oxygen, and then there's a little bit of argon, 1% argon and inert gases, but only 0.04% is carbon dioxide, so it's very small in there. So we know that atmospheric pressure is 760 millimeters of mercury. That means that oxygen at 21% gives you an atmospheric pressure of 160 millimeters of mercury in the body, in the lung to start. So the starting pressure of oxygen here to be pumped around is 160. If you're at 16,000 feet, it will drop down to 82% because the partial pressure of oxygen is much lower. Okay, so I'm going to whip through this because this is all just a matter of how we transport it around. We know that it's transported by hemoglobin. Some oxygen is delivered in the plasma, but it's only about 1 in 4%, 1 in 40%. Oxygen saturation we talked about, the Bohr effect. Markers, strong muscle weakens to carbon dioxide, but more important probably xanthine oxidase. Here we've got the blood leaving the lungs at high tension and returning at 40. Mechanics of breathing, again you can go through when we breathe in and out. When we breathe in normally, we have 3,400 millimeters of air in the lung, and when we breathe out we still got 3,000 in there, so the tidal volume is only 400 mil. We actually exchange during gentle breathing because the rest is dead space. When we force an inspiration in and out, we may increase that to more from 3,400, force it right out to 1,500. When we force it in, we may be lucky to get up to 5 litres or 500,000 mil. So if you've got a vital capacity meter and you really, really practice and blow in there, it's pretty good if you can get up to 5 litres on there. We know the main way that we breathe is the diaphragm and the intercostal muscles, and therefore any mechanical fault of breathing, like cranial, cervical, thoracic diaphragm, manubrial sternal joint, AC, acromial joints, can all affect our mechanics of breathing. So how do we get the oxygen into the blood? We have to pass it through the alveolar. The alveolar are little sacs in the lungs which are very, very rich in capillaries. And this blood is coming from the right side of the heart and being pumped to the lung, oxygenated, and then taken to the left atrium and then pumped around the body. So the alveoli are made of collagen and elastin. When we breathe in, we increase the size of the chest wall, lower the diaphragm down, and so air is sucked in, okay, by change of pressure, chest pressure being greater outside than inside. When we breathe out, it's just a recoil. Unless we really force our air out, when we force our diaphragm and our intercostal muscles. But normally breathing out is a relaxation of the muscles, which is a recoil. And therefore we need elastin as a tissue in our lungs and collagen. So collagen, we know, is the glue that holds us together and gives us the shape of the muscle tissue and the tissues. And elastin gives us the recoil. So if you just pick up the back of your hand, most of us have done this before, pick it up in the middle of the back there and pull it, okay? You pull it, that's collagen. So when you do the sustain test there, a muscle test, that's a test for collagen. When you let it go, that's the recoil, all right? So the time that it takes to recoil is the elastin in the hand. Okay, now as you get older, the elasticity slows down, okay? It's a bit slower and a bit slower and a bit slower. That's the elastin. That elastin in your skin is the same as in your lungs, and it's the same in your gut wall. So elasticity here is the same as elasticity in the lung. So people who've lost the elasticity get emphysema in the lungs because there's no recoil. So they're gasping for air because they can't get that recoil when they breathe out, so they need more air in. So problems with collagen and problems with elastin maybe affect the lung tissue itself. 3 types of cells in there, so let's work through those. So in the plasma membranes we have a phospholipid bilayer, in other words a double layer of phospholipids, and these phospholipids made of phosphatidylcholine, phosphatidylethanolamine, phosphatidylserine and sphingolomyelin. So there's the phospholipid structure. We have the head, and we always have 2 tails with the phospholipid. One tail is a saturate and one tail is an unsaturate. Right, remember that, except in the neurons when both tails are unsaturates. So there's a 5th phospholipid in some tissues, which is phosphatidylinositol. So I want to skip through that so we get to the nitty-gritty phospholipids. So here we've got the 2 tails. And you see one tail is unsaturated, it has a kink in it, and the other tail is saturated or straight. Now saturated oils have generally higher melting points. Yeah, in other words, saturated oils tend to be solid at room temperature, and unsaturated oils are liquid at room temperature. Unsaturates have one double bond, which is like a kink, or more than one, in which case they're called polyunsaturates. So if they're a single, they're called a monounsaturated, and if they're lots, they're called polyunsaturates. Right? Now when you heat an unsaturated oil up, you're left with the same structure, but the molecule twists and turns, okay, and it straightens out. And that gives it the chemical properties the same as a saturate. So a heated vegetable oil, which has been turned, which goes from a cis to a trans form, increases its melting point. So it then acts as a saturate, although it locks on to the unsaturated position. So you've got a perfectly normal phospholipid structure with a much higher melting point. And this is what's happened to human beings over the last 50 years, is their melting points have increased. So in other words, we've become harder. And a harder membrane means it's harder to get nutrients and things across into the cell and diffuse oxygen in, and bad guys or xenobiotics out. So it's a bit more like having cell membranes made of ping pong balls rather than bubbles in the bath. Okay, we're getting a bit harder. So thou should not eat saturated oil, thou should not eat trans fats. In other words, heated vegetables. So the less you eat of that, the better. The only way you can get rid of a trans fat is to take more cis fat. In other words, cold pressed oils. Okay? So cold pressed and obviously organic oils, that goes without saying really. So if you want to displace bad oils in the body, you've got to flood it with good oils, okay? Because the body's constantly changing old oils for good oils. We were fortunate with Eric Perotti, as some of you know. The other week when he came over, he bought us 2 of his new bottles of olive oil, and that's about as fresh as you can get from his olive oil groves. And he said that the highest temperature that went to was 26 degrees centigrade. That's cold press for you, isn't it? You know, that is real cold pressing. Because officially cold pressing for most seed oils is 100 degrees centigrade. It mustn't go above 100 because they start to change. But for olive oil, it has to be, I think he said 30 was the maximum that is permitted to call it cold pressed. Okay, so one phospholipid tail will be saturated and one unsaturated, except in the neuron, when both are unsaturated, so they've got kinks. Now, if you've got a kink, you can become trans fat if you heat it, but an unsaturated can also go rancid. That means it can have an oxygen molecule attached to it through oxidation reactions. So that's a rancid oil, and that's a functionless oil as well. So rancid oils are not good. So you can peroxidize or oxidize them by adding air or oxygen to the oil. This is why you should never leave the top off your bottle of oil. You should always put the top on, and of course you should always keep your oil in mirror glass. It's to stop the light from going through, because the oxidizing light. If you put it in plain bottles, which is what they always sell in the shop, and you have the light through, and you take the top off, you've got air, and you keep it by the side of your cooker, you've got heat, air, and light. And that'll go rancid quicker than anything else. So at least with mirror glass, you stop the light. If you keep it in the fridge, you'll keep it cool and keep the top on so you keep the oxygen away. So that's how you preserve it. Now, we said that neurons are different because neurons are both unsaturated, which makes them highly more liable to oxidation reactions. Okay. Now, one of those unsaturates in the brain will tend to be arachidonic acid. It's an omega-6 oil. The other one could be DHA, which is a 6 double-bonded one, or DPA, which is a 5 double-bonded one. So in the brain, in the neuron, both phospholipids, the C1 and C2 tails, are unsaturated. One will always be arachidonic acid, which is an omega-6, and the other one will be something like EPA or DHA, particularly in the frontal lobes. So DHA is the longest unsaturated oil that the body uses. It's got 6 double bonds, which makes it very vulnerable to air and oxidation. This is rich in fish oil and in algae oil, DHA, which you can make from algae. But it is very highly oxidizable, so you've really got to look after that oil. There are certain areas in the body which both tails are DHA, and the most important one is the back of the eye, the retina of the eye. So both phospholipid tails in the back of the eye and the retina are DHA, which makes the back of the eye the most vulnerable part in the whole body. So if you expose it to light and to oxygen and heat, it can damage. So in a minute I'm going to demonstrate that probably half the people in the room here are pouring hydrogen peroxide onto it. That'll oxidize the retina. Okay, and then they start getting visual problems, as you guess. All right. So this is why we've really got to look after the eyes more than any other area in the body. But the second other organs which have DHA in both phospholipids are the adrenal glands and the testes and the ovaries. So these are worth looking at. Now I suspect the pancreas is as well, because you hear of people getting pancreatic cancers and pancreatic failure, almost like that. They develop type 1 diabetes. They're almost okay one moment, and next day they wake up and they've got type 1 diabetes. Why? You know, something pretty drastic has happened in there. So I suspect the pancreas might be loaded with DHA in addition, or be very vulnerable to oxidative stresses. So the outer part of the membrane here is more aqueous, and the inner part is hydrophobic, so it doesn't like water. So it acts as a semi-permeable membrane, which allows oxygen and certain nutrients to cross it, but not anything. So here we form like the double tadpole with the heads facing inwards and outwards. Now here we see outside of the cell membrane here, by simple diffusion passing through, and this is what oxygen does. It passes through the membrane from outside to inside. Some compounds pass through channels. Okay, so more complex molecules can pass through channels, and some come back out again, which are active pumps through channels, which require ATP to eliminate them out of the cell membrane. But it's this one we're really interested with, the oxygen, is simple diffusion. The greater the pressure outside, the more oxygen will go in. It's as simple as that. So key nutrients for synthesizing phospholipids would be the acetyl-CoA, which we saw with the energy pathway, which involves B3, B5, magnesium. We need choline, serine, inositol. We need our base oils, it's both saturated and unsaturated, and we need lecithin. So let's get that one. Right, quantity of oxygen carried by the saturated blood will depend upon the hemoglobin content. With an average normal of 14.5 is the figure you get back from when you have a blood test done, and anything below about 12 would be considered to be really low in oxygen.